So I think with the increasing age group and we're addressing more and more elder patients, so this is going to be the issue of doing a zero contrast or low contrast TAVI. So TAVI has become an established treatment for patients with severe symptomatic aortic stenosis, and post-procedure AKI is a concern, especially with the borderline and EGFR being reduced in the patients. Patients with pre-existing chronic renal impairment are at particularly high risk, and the etiology of AKI is multifactorial, plus most important thing is the amount of contrast you use. The valve which you use also matters, so meticulous planning is to be done for doing this kind of procedures. So contrast-free TAVR with the TE guidance is feasible. Not for all the patients, but deserving patients should be planned very well. It has got its own level of periprocedural complexity and even morbidity. MRI, yeah, that's one thing we have to discuss because we are more used to the CT films. So non-contrast MRI is a non-invasive and radiation-free diagnostic test that can prove critical pre-TBI planning, but unfortunately, there is no software for MRI to sort of quantify to come out with the diagnosis of what areas or what perimeters of the valve as we have in CT. So recent studies demonstrated that information from both MRI and ECG-gated CTA in perioperative assessment of patient undergoing TAVI is reproducible. So limitations are, as you all know, MRI is going to be very, very claustrophobic. Breath holding is difficult because these are sick patients, especially the elderly patients, and longer scan time, plus if there is a analysis for the software for the MRI is not available as it's available in the CT3 Mencios, and not all patients can undergo MRI. The related contraindications are severe claustrophobia, then life-threatening, sometimes life-threatening arrhythmias which cannot sort of be assessed in that small tunnel over there, and many of the non-MRI friendly devices which are implanted in the body can interfere for a patient to undergo an MRI. So these have to be remembered. CT remains gold standard. We can know everything through it, the calcium score and the height of the coronaries, the SOV and STJ diameters, and LVOT calciums and so on and so forth. So coming to my case, this is an 80-year-old male. This is our first experience in low contrast or zero contrast TAVI. His baseline creatinine, he had a grade 4 CKD with creatinine hovering around 3.5. Mean gradients were 58 and no aortic regurgitation. So the planning was first to do a non-contrast CV, ensure to have an experienced clinical specialist to analyze the CT, and calcium becomes an important marker, involve echo imaging specialties for more input. So this is very important. How do you take the diameters in a non-contrast CT? So the calcium markers everywhere play a very important role. As you can see with this kind of situation, we could make out that the area derived perimeter was around 23. So this specks of calcium has to be studied very carefully. And of course, with this kind of situation, we can make out the SOV diameters, the LCA length, and the RCA. If it's not calcified, then things becomes more difficult, but this patient was favorably, we could measure a lot of things in this. Then the same thing, if you can see the diameters in the diameters of the STJ were quite comfortable. This is very interesting to measure the iliacs. So what they do is you sort of scroll down from the aorta and keep scrolling down unless you come to the iliacs. And once you come to the iliacs, you get a fair idea of the measurements of the iliacs. And presence of calcium also over there gives you a fair idea. If this patient had a roomy iliacs of more than 8 to 10 millimeters. So our planning was ultrasound guided access puncture, minimal or no contrast at all. Annual sizing was in the range. It was 23, it was not overlapping. If there is overlapping, then probably you can take a balloon sizing and then sort of size your valve. Here we chose to implant a 23 millimeter S3 valve. So this is the puncture, and how do you get the coplanar view? There are two ways of doing it. You put multiple pigtails, one in the non-coronary cusp, one in the right coronary cusp, and the left coronary cusp. Keep all the pigtail over there, get your coplanar view. It's very difficult to put a pigtail in the left coronary sinus, so angled pigtail was not available. So we put a AL1 diagnostic catheter, and we got our coplanar views. Once we get this, freeze this view, and then we know, and there's a bit of calcium which is also there, which will also guide us. So we took a small 5 ml shoot to get the coplanar view. And once this is done, then the typical steps of TAVI, nothing great, just straightforward, crossing with the AL1 catheter with the soft-tipped wire, and then exchanging that with a double-length wire, and then a pigtail, and then extra small safari wire. Once that was done, so this is the valve positioning, and once the valve is positioned over there, we take a small 3 ml shoot just to make sure your position is fine, and then the deployment of the valve is done. So there are no more shoots after that. Everything is based on echo assessment, and then hemodynamic assessment is done by putting a pigtail, measuring the gradients, and then the most of the information is by the echo. Transesophageal would be a better way of assessing it, but we did it transthoracically. And finally, vascular closure with the 3 ml of injection, and then we know that there is no complications in the vascular access site. So final result, 11 ml of total contrast, 24 minutes procedure time, precise positioning, no AR, and the final gradients were 4 millimeters of mercury. So key takeaways, CT remains the gold standard for pre-TAVR analysis. MRI could be the future, but analysis software unavailable as of now. Non-contrast CT can be tricky. Ensure as accurate as analysis is possible. Plan the bare minimum shots needed. Using hardwares exclusive to give additional support, for example, catheter marker, balloon sizing for overlapping annulus, etc. Some people place 3 wires in all the 3 cusp, but somehow wire is very uncomfortable. It keeps on floating. It doesn't deep seat like a pigtail. Last but not least, choose the valve which requires a quick sort of positioning without much contrast and faster deployment. Thank you very much.